Hello everybody, my name is Richard, I'm the Trust's Chief Executive. We talk a lot in Sandwell and West Birmingham NHS Trust about delivering the fundamentals of care, getting things consistently right for patients and their carers. One fundamental of care is providing a good and dignified death for people in their communities and their own homes as much as in our hospitals. And that is as important to me as the provision of the life-saving treatment that we are used to giving. Please engage in this agenda, this hugely important work. It's as important to me personally as it is to our organisation. Thank you.
Hello, I'm Mark Anderson, Chief Medical Officer at Sandwell and West Birmingham, but I've also worked in acute medicine for over 20 years. So I'm only too well aware of how many of our patients, particularly those with frailty, organ failure or multiple comorbidities, would benefit from a more coordinated approach to care, which means involving early palliative care alongside our best appropriate treatments, so we provide a more integrated approach to their care.
Hi, I'm Mel Roberts. I'm the Chief Nurse at Sandwell and West Birmingham Hospitals. Navigating the healthcare system for patients and families at end of life can be really challenging and difficult. What we want and what's important to us is to make that experience the best for them. For us to do that, we need to listen to them. We listen to hear what they say and respect their wishes. If we do that, that will help them have the best experience possible for both the family and the patient when at end of life.
Hello, my name is Mike and I'm one of the doctors from the palliative care team and also part of the wellbeing team and the trust. So how can we approach this opportunity to make end-of-life care the best it can be at SWBH? Well, there are 5 key principles we'd like to share. The first is early identification. Who is it that needs palliative and end-of-life care input? Sometimes it's not always clear, and so we would recommend using the SPICT tool, the Supportive and Palliative Care Indicator tool, which is a validated tool to help identify such patients. Secondly, we want to encourage meaningful conversations. Conversations that are kind and are clear, to help both patients and their relatives plan and prepare for the future. Thirdly, we say let's document and share those plans using the supportive care plan so that whoever contributes to the care of the patient is clear on the priorities and the focus of care. Fourthly, regularly reviewing the physical, social, psychological and spiritual needs of our patients, which may change from one day to the next, so that we can deliver excellent holistic care. And fifthly, achieving excellent symptom control, using non-pharmacology and pharmacology in order to meet the needs of the specific patient before us. So it's about recognizing, communicating, documenting and sharing, reviewing, and holistic symptom control. I'd like now to introduce Paul, whose father died within the care of the trust.
My dad was, he was an extraordinary man. He was 87, but he'd been working in Africa until about a year before. He got married about 5 months before he died. And he just loved people. And he was one of a kind. One night he just couldn't breathe and he fell down going to the toilet in the middle of the night. They had to call the ambulance. And he was admitted to Sandwell, and he had bilateral pneumothoraces, and he essentially had metastatic spread from the undiagnosed tumour in his lungs. But it was difficult because no one really wanted to say that to him because he didn't know he got cancer. So they stuck chest drains in, and so he was seen by acute medical doctors and geriatricians. They were trying to get him out and trying to sort of say, well, we'll get the chest drains in and then we'll the pneumothoraces will seal and then you'll be able to go home. And he did that for a few days and you could see he was deteriorating. He couldn't really eat and he wasn't really saying much. He couldn't get around the ward much, and although there were lots of people coming around to see him, nobody was actually communicating with him about what was going on. What changed things for the better was senior doctors taking stock of the situation, which to be honest didn't take very long to do. Yeah, this guy's clearly dying, isn't he? Let's go ahead and treat him as if that's what's going on, and treat the family as if that's what's going on. and stop pretending, actually, if I'm honest, that everything's all right. For my family, talking honestly to my father and to us about death made all the difference, because it took away the angst and the fear and the uncertainty from our minds, and from the relationship we were having in the hospital with people who weren't giving him what he needed, frankly. And when that conversation was had, it was a moment of epiphany for me, because I couldn't quite believe how quickly people could change in how they dealt with him. They suddenly had something to do. The nurses, the doctors knew how to treat a man who was dying once they decided that he was dying. You saw the strength of their compassion coming through. So the level of kindness, if you like, was different. The symptom control, the attention to what was needed in the moment. There was a patience with us. It was a genuine sense of kindness, which made a huge difference to us in those last couple of days.
Hello, my name's Sue Law and I'm the Service Lead for End of Life and Palliative Care Team. Today we'd like to talk to you about how you can help us to improve end of life care in all of the environments that we care for our patients. So some of the resources that we've got are available on our Trust intranet site. Look for Connected Palliative Care and there it will signpost you to lots of resources, including training that's available, leaflets for family members, information for you, all different types of symptom control. So there is an awful lot of resource. So please go and have a look at that. It will help you to deliver that excellent care to your patients. Talk to your ward managers and your leaders. They've got a dashboard. You can look at that dashboard. On the dashboard, it will show you exactly how you're doing with improving end-of-life care and maybe some of the areas where you might want to improve a little bit more. To help you with this, we've trained up ward champions. So the champions on your wards will be trained to a higher level and they will be able to support you. And one of the other things that we've done to support you is made sure that we've got our team ready to help you. So we've got specialist nurses and we've got doctors. They are around on the wards. What you probably don't realise is that we've got those resources in the hub. So we've got our Connected Palliative Care Hub, we've got an urgent response team, we've got a register of our patients. So as soon as you know who's dying, you need to let us know and we can support you in delivering that care. We've got a day hospice and we've got our OT, Macmillan team. A fantastic resource, but we can only help you when you let us know about those patients. So if we all work together, we can improve end-of-life care for our patients.
So what might your next steps be? Well, we would suggest creating space within your teams for compassionate conversations around death and dying and bereavement. These things affect us all, and so we need to normalise conversations about them. We'd also suggest talking to your line manager to identify how your knowledge and skills may be enhanced so that you're ready to play your part when delivering care for someone approaching the end of life. Earlier on, Sue mentioned about some of the different resources that are available on the intranet. Perhaps now's the time to go and look at those for yourself. And lastly, think about your particular department. How could end-of-life care be improved within your department? No matter how good we're delivering end-of-life care, it could always be just a little bit better. Think about how it could be just a little bit better where you work, and perhaps turn that into a quality improvement activity.
My name's Rachel Hendrickson-Brown. I'm the Macmillan Therapy Lead, working alongside palliative care. In conclusion, to close, it is very clear that regardless of race, gender, sexual orientation, religion, or ethnic background, a loved one becoming palliative or facing the prospect of death is something that transcends all of our differences. It unites us in not only a feeling of grief and loss, but most importantly, a feeling of love. Therefore, by everyone making a conscious effort to provide quality palliative and end-of-life care, we can positively impact not only our patients, but staff, relatives, and even the local community to heal the wounds that we know that grief can cause. So let's make palliative care everyone's business.